this myth that you have to sit with your back straight and your shoulders back, that's been proven to be complete nonsense. I've seen patients undergo surgery to try and create a curvature using metalwork, and they failed. And that's something we really need to move away from, this business about the alignment. You've got to trust your spine. It's just teaching someone to trust their spine again is massively important. So the key thing is to just keep moving, try and move through it. And that's my core belief. My strapline is keeping people moving. I think that's really important.
Right, hello everybody. Welcome to an expert interview series here on the HT Physio YouTube channel. My name is Will Harlow and I am an over-50s specialist physio. And I'm joined today by a very special guest. We've got Anthony Ghosh, the spinal neurosurgeon, speaking with us today. So we're very lucky to have Anthony here. And I'll start off just by asking Anthony to introduce himself. So welcome to the show, Anthony. And can you start by telling everyone a little bit about yourself?
Hi, Will, and thank you. I'm looking forward to this. Should be an interesting discussion. Yeah, so I'm a consultant spinal neurosurgeon, and I run a practice called the Spine MDT, or Spine Multidisciplinary Team. So my practice is essentially a big network organisation of all the different healthcare professionals who treat back pain and spine-related problems. So that includes, for example, physiotherapists like yourself, osteopaths, other surgeons and pain specialists. The network is mostly in London, Essex and Kent, but we see patients from all over. And the idea is by bringing all these different skill sets together, we can usually find a solution for any spine or back related problem, but give patients that overall oversight or accountability to find a solution.
That's fantastic. It sounds like such a great organisation, and it's great to hear that there's things like that springing up all around the country, and it sounds like you're really leading the way on the MDT approach, which is so important for people with these problems. Yeah. It was funny actually, because I know I joined you actually for an interview several weeks back and had a great time. And when I hopped off the interview, my wife says, "You were just speaking to a spinal surgeon?" And I was like, "Yeah." And she said, "It's funny that, because all I could hear was you talking. I couldn't hear any of him talking. So maybe you should get him back on and get his insights on back pain, not just yours." And I was like, "You're absolutely right. We're speaking to a true expert and it's just me waffling on." So that's why I wanted to do today's interview, to get your insights really onto.
I was interviewing you, so I really wanted to know your views on things. So yeah.
Oh, it's good anyway. So fantastic. So can you tell us a little bit about your journey into doing what you do now, Anthony? How did you start off and what's led you to where you are now?
Well, actually, ever since I was a child doing biology at school, I was always interested in, I just got really fascinated by the nervous system, specifically, and how it keeps us moving. And then when I was in medical school, I got exposed to some neurosurgery, and it just blew me away. So I decided that was the career path I was going to go down. And then in my neurosurgery training, it's crudely split into the brain and the spine. And what I enjoyed about the spine was the sort of team approach. The team approach and planning is a really important aspect of the care. The majority of conditions aren't managed surgically. So that MDT approach, sitting in a room with physiotherapists, for example, pain specialists and surgeons, going through the scans, the patient's history to find the solution, and all the planning, was what really got me excited. But also the outcome of treatment is taking somebody who is, say, debilitated by pain or even some neurological dysfunction, can't move, and then finding a solution that gets them back into their normal activity, gets them moving again. That's something that just really excites me.
I think it's a really sort of new age approach, isn't it? Because from my conversations with maybe old school surgeons, as I would call them, the way they were taught is like, you're going to see a problem, you've got to operate on it, and then basically you just push the patient somewhere else, and they make the best of it, really. But I think your approach of like integrating everyone from the team into helping that patient is a much more modern approach, and I'm guessing the outcomes of that are much better.
That's right, because we're often unaware of solutions that can be offered by other healthcare professionals. I'm not a physiotherapist. I often don't know. And it's fascinating when you sit in a room and they say, well, actually, we can try this program first. I've seen this before and this has worked. And it saved me from doing sometimes a very complex operation that you can be a bit apprehensive about. So it's vital that you have that team approach.
Yeah, I can totally understand that. So my audience are basically exclusively people over the age of 50, and I know that you have a lot of 50 plus patients in your practice too. Can you tell the audience a little bit about some of the common things that you see in this population and the sort of things that people are dealing with?
Yeah. Well, interestingly, that's the age group where you see a lot more back pain, 50 and upwards, or spine-related problems. I like to break it down into 4 categories. The first 2 being acute and chronic. So something that started very suddenly, very recently, that usually settles down, or chronic that's been going on for some time. And within those 2 categories, I like to use the terms pathological and non-pathological. I don't like the term non-specific. I find it a bit of a cop-out. There's always a cause, but that doesn't necessarily mean there's an underlying disease. So in the acute setting that's come on fairly recently, often you see problems like, a strain in the muscle, and I would call that non-pathological. Or sometimes a bit of wear and tear in the facet joints. That's commonly seen in people over 50s. And that's not necessarily pathological, but it is a cause. And so the pattern you see is with, say, for example, the facet joint pain. These are the joints of the arches at the back of the spine that join each vertebral body together. But, they're often quite stiff in the morning, and when patients get moving, it eases a bit. Standing up straight, often like pulling yourself back, is what triggers the pain a bit, because that's what compresses the facet joint. So these are common things I see. Muscular strains, again, they settle down. And then these problems, they have flare-ups which are acute, but then often patients get into these patterns, or what we call guarding behaviours. And that's often from myths and abnormal beliefs about postures, and that can actually lead to more chronic pain in the back. And again, a lot of this stuff that I'm talking about can be managed non-operatively, as you know. Common things that I see as a surgeon is in over 50s is when nerves start to get irritated or bothered, and that's kind of when I get involved. Not always, it's still a minority. So for example, spinal stenosis, you start to see it in patients who get slightly older, above 50, 60, more common in the sort of 60s and 70s, where the tissues just thicken up. I kind of think of it as calluses forming in bones that are rubbing together. The facet joints, as they're rubbing together, they thicken up a bit. The ligaments thicken up. The disc bulges again ever so slightly. So that canal, that channel in the middle of the spine through which the nerves run through, just narrows down, tightens around the nerves. And patients often say that, when they're sitting still, they're fine. When they get up and walk, the back pain and even leg pain starts to come on. That's a sign of that. Again, that can be treated non-surgically with some of the stretches that you've described in your videos, Will, quite useful. And when that fails, yes, there are today some minimally invasive surgical approaches we can do that have good, long-lasting results.
That makes perfect sense. Yeah, we see a lot of stenosis, and it's a tricky condition to treat from a physiotherapist's point of view, because as you said, we're actually dealing now with structural changes, not just just pain without any obvious structural cause. Stenosis is quite different. So what kind of signs might you look for that suggests that someone is dealing with these structural changes as opposed to, muscular problems or issues that might be better off dealt with by physio and exercises? What sort of signs would you look for?
So again, I try and break it down into like the pathological, so stenosis with, if they've got pain that's going down the legs, and it has started to affect the legs now. So they've got pain and numbness building up in the legs when they walk. The walking distance or standing time has just shortened and shortened. And they've exhausted physiotherapy measures. They've tried various stretches where you, one you described beautifully, where you peel yourself off a wall. You're up against the back of a chair or a wall, and you peel yourself off it to stretch the ligaments and thin them out. If that's failed, and the scan shows quite a significant or severe amount of stenosis where you simply lose all of that space around the nerves, then these are the patients I think, well, okay, we can help you here with something that's fairly minimally invasive. Other pathological conditions are, you've probably heard of spondylolisthesis, where one bone of the spine slips forward gradually over the bone beneath it. That can be just down to a very worn facet joint and ligaments becoming so lax that it's allowed that to happen. That in itself can cause stenosis, narrowing of the spine and pinching of the nerve. So again, patients, when they stand, the pain just builds up. They have to lean on things to try and ease it up, or sit down even, or turning in bed at night when they roll over from one side to the other. That movement tells you that there's instability of that segment. So these are the key things where we can do a procedure to realign those two bones if they are unstable and fuse them together. So that's probably the commonest scenario where I fuse the spine, if people have heard of fusion, and that's a minority of the surgery I do.
Yeah, that makes sense. I think, as you alluded to there, sort of the minimally invasive surgeries are always preferable, usually, aren't they? If they're going to be the ones that will help the problem, as opposed to anything that is more invasive. This is a really difficult question to answer, but we know from MRI scans that a lot of these changes we've been talking about, like narrowing of those areas where the nerves travel through, and even spondylolisthesis to some degree, we see those in people who don't have symptoms.
Exactly, yes.
So how much are these normal aging changes, and how much are these things that people should worry about? I know that's a really tricky question to answer, but if you can try and give your perspective on that, I'd be really interested to hear.
Well, over the age of 50, in people, as you said, without back pain, worn discs, slightly worn facet joints, even a bit of stenosis and a mild spondylolisthesis, all of these, some or all of these things are seen in at least half of that population who don't have pain. So in medicine, we say treat the patient, not the scan. Do the signs and symptoms fit with this? Often, actually, they don't. So in the context of, when you see stenosis, if it is pain that's worse on walking or standing for a period of time, okay, that could be related. The same with spondylolisthesis. Slightly worn facet joints, dark discs, things like that. It's very rare they're the cause of pain. In the slightly younger population of the over-50s, so people within that first decade, acute tears in discs, the sort of lining that contains the disc. So disc material, the textbooks often describe it as looking like crab meat, which is actually quite an accurate description. It's like a soft, gelatinous, squishy bit of material that's contained in a lining that's almost like a fabric. That fabric often tears, and then a bit of that material leaks out, which is quite inflammatory, and that causes a big sting around all the tissues locally, inflammatory response, and it usually settles down, and then scar tissue builds up around it. That scar tissue is made of a stuff called collagen, which is actually what is found in the lining of the spine anyway. So that usually repairs itself. But what a pattern you sometimes see is that it just keeps tearing and keeps tearing, keeps causing pain. And then eventually these disc spaces don't have, a normal disc space doesn't have nerve endings in it and doesn't even have a blood supply. But if you keep building up repeated inflammation, then you start to develop blood vessels and nerve endings in that space. And that's what I'm trying to look for with various tests, both clinical, but also on various scans I do. But that makes up a tiny minority of patients.
Yeah, that makes sense. And I mean, as a surgeon, you're very lucky in some ways to get an insight into what these tissues actually look like.
Yeah.
Because as physios, we learn stuff from the textbook, and you might occasionally examine, like a body part or something in your university days. Out in the real world, everything is covered by skin. We don't see any of these tissues. So to actually get an insight into how they look must be fascinating. One thing I often tell my patients, especially ones who've had issues with discs or irritation to nerves, is that when it comes to nerve pain, people are often dealing with at least two factors there. You've got the mechanical pressure on the nerve, but as you say, you've also got that inflammation where the body reacts to the disc material. It doesn't like it being there.
Yeah.
And then you get all the histamines and the other chemicals that cause that inflammation too. And that almost compounds the pain. So super interesting. I think it's important that people kind of understand what's actually going on in these areas of the body.
That's right, because a nerve can actually tolerate a fair amount of compression. You sometimes see a patient with a good-sized disc herniation where a disc starts to poke out and pinch the nerve, but it's been there for quite some time, it's scarred over, and after a while the pain disappears, yet for some reason they've had a scan because they're all available now, and they've still got that compression, and they're not in any pain. And that's why in the majority in that acute phase with the inflammation, most of the pain is actually from the inflammation. When that settles, the pain goes despite there being mechanical compression.
Yeah, makes sense. And it's difficult sometimes to wrap your head around these things, isn't it? And I think that's where some of these myths around, the pain always being as a result of structural damage come from. Yeah. What are some of the other myths that you hear about back pain in your practice that you try and teach people about?
Well, two main categories now with the availability of MRI scans. Patients can literally walk into an MRI scanner without a referral and pay for a scan. They get a detailed report, which a radiologist has to write by duty. And then they often come to me and say, look, my spine's ruined. It's ruined. It's full of disease. These normal wear and tear changes described, which could sometimes make a whole A4 page, are just normal findings of age. And the analogy I use is, I don't go to a dermatologist now that I've got wrinkles on my skin. It's just part of being human. So what findings on an MRI scan don't often correlate with anything bad necessarily. And something that's really grown over the years is this myth about posture. And I think you've heard of Peter O'Sullivan, quite a famous professor of physiotherapy, has done extensive research on this. This myth that you have to sit with your back straight and your shoulders back, and that's why you've got back pain, because you've got a bad posture. Or also some things about the core. Your pain is there because your core is weak. This group of muscles that support the spine. That's been proven to be complete nonsense. I mean, I've treated the occasional athlete or bodybuilder with back pain. They don't have a weak core. Yeah. The reason we slouch when we sit down is because that's our muscles relaxing. We don't have we don't walk around with our biceps flexed all day. There's the same thing.
Yeah, absolutely. I often say to my patients as well, like, have you ever tried to sit up really straight for 3 hours at a time? But you're going to be in pain at the end of that. It's not comfortable. So, slouching sometimes is normal. Sitting up straight sometimes is normal. We're built to be in these different positions.
That's right. The problem is when you're doing that for 8 hours a day, it's not so much the slouching, it's just the not moving. The spine likes to move.
Yeah, I totally agree.
Yeah.
So, I mean, I wonder how different your patient population is to mine, Anthony, because I mean, if they're coming to see you and your MDT, I would assume that a good proportion of them have already tried many other things that haven't worked. Would you say that's correct?
That's right. It's very rare I see a patient who has come to see me as the very first healthcare professional they're seeing. There are exceptions to that, in trauma. Trauma, I see the occasional fracture of the spine or a very acute, severe slip disc causing severe leg pain, maybe. But usually they've seen somebody else first, like a physiotherapist or their general practitioner who's decided to get a scan on them, and then they've come to see me because of findings on that scan, or they've just failed. They've tried all the extensive physiotherapy treatment and unfortunately haven't improved.
Yeah. And as a proportion of the people who come to your MDT, how many would you say eventually go on to have surgery, and how many can your team sort without having to go under the knife?
Of the people I see, I'd say 1 in 10 end up having surgery. And I'm a big believer that if you're doing more than that as a surgeon, then you're over-treating people, and it's a sign that you're not working with other healthcare professionals enough. And remember, that 1 in 10 in my practice have already been through a filter. They've already, a lot of them have actually done other treatments, and we still manage to find, for the majority, a non-surgical solution.
I think that's so good. And that's such a That did actually surprise me there. I thought you were going to say something like 3 or 4 in 10.
No.
But what 1 in 10 is amazing. One thing that sticks out to me about that is that I hear people sometimes say that, oh, I've been for 3 or 4 sessions of NHS physio and it didn't work, so I failed physiotherapy.
Yeah, that's
And
yeah.
I think many times it's like there are so many different approaches you can take within physiotherapy or within conservative management. And just because you met one physio, it didn't work out for you with them, it doesn't necessarily mean that it would never work. And I guess you've got a really, specialist expert team there who've seen so many different things that people come with before, that they can offer a unique approach that maybe people can't get elsewhere.
That's right. I think it comes down to identifying the cause. I mean, as I said earlier, I don't believe in non-specific back pain. I always think there is a cause. It may not necessarily be pathological, a disease process, but sometimes if you can identify a cause, whether it's functional, which is the majority, which it comes down to certain behaviours, or whether there is a structural cause, as I often can find in some, with a good analysis of the scan and tying it in with the clinical symptoms, then I can at least give the physiotherapist, this is where I believe it's coming from, and therefore the physiotherapist or osteopath then has something to work with, a program that's designed around that, and that often gets you good results.
Yeah, that makes perfect sense. So for someone who's got, let's say, just kind of mechanical back pain, you've had a look at them, there's nothing that you feel they need to have done surgically at this time. What sort of a role do you think diet and exercise play for that person, and then just general lifestyle as well?
That's a really good question, actually. Going back to Peter O'Sullivan's research, he's found that actually maintaining good overall health, rather than very focused treatment on the back, has far better long-term outcomes. Than this business about strengthening the core and watching your posture. Maintaining good health, good weight, moving, exercise, generic exercise, actually has better long-term benefits on the back. Patients find that hard to believe in the beginning because they're in debilitating pain often at the start of the journey, can't get into the exercise. But once you can get them moving, that's the first stage. Once you can get them moving, then things do improve if you have a good, healthy lifestyle.
Yeah, I think lifestyle is so important. And we see some amazing evidence for things as simple as walking, helping people with back pain. And I think I said to you when you interviewed me that sometimes it makes you question your role as a physio when you see that randomized controlled trials that compare just walking to physiotherapy treatment. Often the walking program is just as good or even better.
That's right.
I think there's so many things.
That's right. I think where we can, we've got to try and, when it's non-pathological, as we said, when patients have those normal wear and tear changes we see, our role is to try and demedicalize this and not get people to think of it as a disease or a condition anymore. So sometimes instead of a physiotherapy program, I'll advise them to just try and join a class of some sort. That way they're in a community of people and it's just out of that clinical environment.
Yeah, I think, and having that support aspect as well is key. I actually did my dissertation on the comparison of individual exercise treatment to group exercise treatment for chronic lower back pain. And I did a systematic review and I found that there was basically no difference between the two conditions in all the studies. The improvements were just as good for group exercises, individual. So I think that kind of like camaraderie aspect of it really helps too.
Absolutely. The psychological aspects here we're coming on to, that's really important.
Absolutely, yeah. We'll talk more about the psychology of it in a moment because it is just such a key topic.
Yeah.
While we're still on the topic of, looking at people and considering whether or not surgery is an option, are there any kind of main signs that you look for? Are there any things that when a patient mentions it or you spot it in an assessment, you think, this person is probably going to need to have surgery?
Yeah, so there's what we call the red flags. If people have a neurological deficit, my role primarily in the surgery is I'm always asking, are there nerves at threat here? Do I need to save the nerves and therefore save function? So what I look for, if they're developing weakness in the legs, motor deficit from from enough compression of the nerves, that's something you've got to try and reverse as soon as possible. The evidence has demonstrated that the sooner you take the pressure off a nerve that is then causing weakness, and they're experiencing weakness, the more likely they are to regain the power in the legs. So these are the signs I look for when I'm examining, the power in the legs. Can they stand on tiptoe? Foot drops are commonly seen, where the foot and the ankle becomes floppy. So I'm examining the power in the legs. So if they mention to me, look, I'm finding it difficult to climb stairs, or my legs fatigue, they give way, things like that are really important signs. But also pain, pain again from the nerves. If again they failed the basic treatment, it hasn't settled down within a few weeks, as most patients will, then you start to think about, okay, let's look at some imaging here and see if there's something I can do to reverse that.
Yeah, that makes sense.
Yeah.
How fast do you have to act if someone does have like a nerve deficit, they've got a foot drop or something? How quickly do you think it's important to have that intervention? Because I know time's of the essence if you've got a nerve that's sort of impeded or blocked.
It often depends on how weak it is. So there's a recent publication. If a nerve has if a nerve has lost its power completely, so it's complete. So for example, with a foot drop is a common one we see, because it's the lower discs of the spine that usually herniate and pinch nerves. And those nerves are the nerves that either we tiptoe, that we use to flex the ankle and tiptoe on, or pull the ankle back. And if you've got grade 1 power where it's literally floppy, you just cannot move it, we're talking within the first few days. If there's a bit of power, the evidence of suggesting as early as a few weeks, even if it's a few weeks later, there's still a chance of gaining some strength back. We used to say before, if you've developed some weakness and it's already got past a few days, 24 or 48 hours, it's too late. That's actually not true. If there's some function there, there's always something you can gain. It may not be much, but even if you go in late, there's something to gain. So the answer is, as early as you can.
That makes sense. I think that's good to hear, actually, from my point of view, because the sort of protocol we work off in my clinic is if someone has lost power, but they can still take that muscle basically through its full range and they can still push a little bit, then you're probably best working on it conservatively first. And many times those people regain it.
And actually, if there is some regain, if it's regaining even a little bit, that's an indication not to operate.
Oh, great.
If you're starting to see improvement, albeit a small amount, surgery is not necessarily going to accelerate that. So that's an indication not to operate if you're seeing improvement.
That makes sense. So for someone who does end up having spinal surgery, I think one of the big things that people worry about is, how long am I going to be out of action for? How long till I can get back to my normal life? What would you say for someone in terms of recovery times, what to expect, and how has that maybe changed since you've started practicing versus now?
That's a good question. So the commonest operations I do in the over-50s are minimally invasive lumbar decompression. That's for stenosis, the narrowing of the spine. So very small incision, now with microscopes and different tissue retractors that hold some of the tissues out of the way for us. You remove all of the overgrown bone and ligament that's compressing nerves and close up. So I usually say with that, it's an overnight stay in hospital. You can do it as a day case. I like the overnight stay because the physiotherapist sees the patient once the drugs and the anaesthesia is all out of their system. And they just get so much more out of that education. It's one night stay in hospital. I usually advise, if you are working, take 2 weeks off work. In that time, I expect you to walk around, potter about in your house, maybe even go outdoors. Don't sit for long periods of time. And then after those 2 weeks, a 4-week phased return to work, where over the 4 weeks, you're just gradually building up the hours. You'd expect to have some stiffness and some pain in the lower back where the wound is, but that just improves day by day, week by week. And then the other operation is a microdiscectomy. So in the younger category, again in the sort of 50s age group, the discs are still soft and therefore can still herniate. It's very rare a disc herniates acutely in someone above, say, 60, for example. It's usually in the younger age groups. And again, it's the same approach. The incision and getting down to the spine, getting to the area to remove that fragment of disc, just to shave that away, is the same approach as the minimally invasive lumbar decompression. And it's the same again, an overnight stay in hospital, 2 weeks off work, during which I expect you to walk around, and then a 4-week phased return to work.
I think that's probably quicker than most people expect.
Yeah, I think so. I mean, in medicine, there's this blanket 6-week mark that everyone seems to throw out there, and that actually comes from the pathology books, which is how long it takes scar tissue to fully set in. But you can still do stuff whilst you're healing. The important thing is to actually keep moving. When you've undergone surgery, in the surgical site around the muscle, there's a build-up of inflammatory chemicals. If you're lying still, they just build up and accumulate, and the muscles, if you like, marinate in that stuff. As we move, those muscles contract. Yes, it will be painful at first, but as those muscles are contracting, they're pumping away all of those chemicals, and therefore that actually speeds up the pain relief thereafter, the healing.
That makes sense. Is there anything else people can do to speed up the healing?
It's mostly, I mean, there's the general wound care, trying to keep that dry for a week or so, and when showering and washing after a week or so, just to dab it dry, not pick at any scars. Gentle walking, getting back into normality, not going over. If you're someone that enjoys exercise, I usually say in the first 2 weeks, don't do much. But there are studies that actually show that even if you're getting back into exercise as early as possible, at a year down the line, you're far more likely to reach your pre-pathological state of exercise, i.e. the way you were before you experienced any pain. So just being a bit careful. So moving, walking, doing some of the light exercises that the physios will give you, some of the stretches important in the first 2 weeks. Thereafter, building it up according to your ability. Running is okay. There's some myths about running causing disc disease. That's complete nonsense. There are some studies that show that in your cartilage, it actually thickens it and strengthens it. Whilst the disc is healing, it can tear a little bit if you've got a lot of impact on your heels. There's some research done on forefoot striking versus heel striking with the advent of trainers today. So I often advise patients, if you want to get on the treadmill or go out for a small jog, test it out, but try it on an incline first.
Oh, that makes sense. Yeah, because you're changing the mechanics there, aren't you?
Yeah.
Okay,
exactly.
good.
That's heel striking. Yeah.
I think that's really. I know this is not just relevant to spinal surgery, but I think it's so important for people to realise that there isn't actually any good evidence that running causes arthritis or breakdown of cartilage, or it could actually be the opposite. And especially for like the kind of recreational running that most people do, that's actually shown to be very good for your joints.
That's right. Look, we're all prone to injury. We all can get injuries, but these are, I don't like using this phrase, but I often say these are freak accidents the majority of the time. You can get accidents, but as a result of that, this myth has been propagated that running is somehow bad for you, which is, as you just said, complete nonsense.
Absolutely. So I think another thing that people obviously really worry about when they're considering spinal surgery is the failure rate and what happens if it doesn't work out. What would you say to someone if you've operated on them, they come back to see you for follow-up and it hasn't had the desired result?
Well, a lot of a chunk of my practice is revision surgery. And I think firstly it comes down to the right, getting the decision right. The index procedure, was it the right thing to do? And that's often why things have gone wrong. It's quite often the wrong thing to do. So examples of that. So times when it hasn't worked in my practice, or when I've operated on someone, it is usually a recurrence. That's what I'd say. So the desired effect, for example, I've taken out a herniated disc, a fragment of disc that's poking out, pinching a nerve, causing pain down the leg. I've shaved that away. Patients have improved, but then within a few days or a couple of weeks, they've had a sudden recurrence of that pain. And the trouble is, the evidence has shown that if you just shave away the piece of disc that's poking out and don't go rummaging around too hard into the disc space to remove everything, the results are better. The flip side is there is some material there that could break away if you do a bit too much, a bit too soon. So if there's a recurrence of the symptoms, I often try and get, it depends how early it is. I often get an MRI scan to see what's going on in that region. And then it's a judgment call on whether they need a repeat operation or whether it's just a very small piece of fragment. Can we watch and wait a little bit longer, and will it settle down? That's usually the key decision to be made.
It's such an individual thing as well, isn't it? I know that's a difficult question to answer, because you don't necessarily have like a set protocol for if a surgery doesn't have the desired outcome. It's got to be based on so many different factors that are all individual to that person.
That's right. In my practice, though, a lot of patients I see are revision patients. They've had surgery elsewhere, it's failed. And then when you go back, when you start from the beginning of the history, look at the scans and look at what the patient's symptoms were, it was the wrong approach.
Yeah. What I'm getting from that is that this is a decision that people need to spend a long time thinking about before they rush into it generally.
That's right, yeah. And as I said earlier, in medicine, we say treat the patient, not the scan.
Yeah.
The test.
It makes perfect sense. How would you say your surgical practice has changed over time, Anthony, since you qualified up to now?
So to qualify, I mean, when I qualified, the way we did a lot of these procedures were through, bigger wounds and big retractors, just so you can get a good view of what's going on. The technology has now improved where the instruments to move the tissues, to hold tissues out of the way, have just improved, so we can do it through much smaller wounds. And then I've applied my skills as I did cranial in my neurosurgery training when we're operating on the brain as well. We use microscopes a lot, so everything's magnified. So doing things things have just become far less invasive now compared to when I started my training. And also, I think that, like I said, in my private practice, working with individuals, we've had better results. There's a concept of prehabilitation. So working with a physiotherapist before surgery, even if you've planned surgery, doing some work beforehand with a physio has been shown in studies to have better results after the surgery. And then having a clear plan with physio, just because I'm operating doesn't mean that's your physiotherapy done with. A team approach is so important to us that, I often say, even if I'm doing my bit, we still need the help of the other team members here.
Yeah, we like to see people before surgery, actually, because I think we mentioned on the other interview, the better you go into surgery, the better you come out. And
conditioning, isn't it?
Exactly, definitely. Now, I want to touch on something we spoke about earlier, which is the psychological side of back pain. We now know that, with the advent of the sort of biopsychosocial model, that the physical changes in someone's spine are only probably a third of the symptoms they're going to get. A lot of it comes down to their psychology. And one thing we see a lot in our practice is, especially for people that have had back pain or back symptoms for a very long time, they're terrified of movement. How would you go about treating or helping someone who has this absolute fear of bending or twisting or moving?
It's a very tricky situation, this, as you said. I often think of pain as a jigsaw puzzle. And as you said, parts of that jigsaw puzzle could be the pathology, i.e. when at the onset of when this started. For example, if a disc is torn, you get that acute pain. So at the offset, the majority of the pieces of that jigsaw puzzles are the pathology, the tear in the disc. And then the other pieces are the fear, stress, and these things, which are potent amplifiers of pain. And then as time goes on, as you said, the pieces of that jigsaw puzzle that are the pathology start to shrink. Maybe it's only one or two of those pieces, and the rest are these potent amplifiers of pain and then behavioural changes. Contrary to what I've said earlier about MRI scans, sometimes having someone sit down with you, go through the actual pictures of the MRI scan with a model of the spine in front of them and just explain and reassure them that, look, you've got to trust your spine. It's just teaching someone to trust their spine again is massively important. And what I always say, a phrase I always use, is actually it's the most robust part of your body. It's the core of your skeleton, or your arms, legs, head come off that spine. It's the structure that's protecting your spinal cord. It's actually the most robust part of your body. Trust it.
I couldn't agree more. I think it's so important to maybe show people how like strong and robust their spines are, and having those models is really helpful, we find, in the practice as well.
Yeah, definitely.
So in terms of someone who has either had surgery and is now recovering, or someone who you've said, you know, you don't need surgery, you need rehab, what kind of a role do you think mindset and mentality has in helping someone to get better?
They have to be shown that there's a light at the end of the tunnel. So if you can explain, if you can explain to them that the spine is fine, without the cop out of saying this is non-specific. I really dislike that phrase. I say, look, the onset of it was possibly caused by this, a tear in the disc, but I often say, look, we're often speculating because we see this a lot of the time. So by explaining to them that there's light at the end of the tunnel, there are people with these findings on their scan that do not suffer with pain, but nonetheless, we're seeing the pattern here, and showing them the evidence of a lot of these treatments, I think it's just giving them that positive belief. It's a huge factor.
Yeah, I absolutely agree. I really like your take actually on the non-specific back pain thing, because it's such a common term. It's one that's never really sat 100% well with me either. And I like your differentiation from not necessarily non-specific, but pathological or not pathological. I think we're going to borrow that and use that in my practice. I'll certainly be showing our physios this interview. So obviously the non-specific stuff, that's something you disagree with in the world of back pain. Are there any other things that you've spotted in either in surgery itself or in just back pain approaches in general that you disagree with or have issues with?
Yeah, I have a real issue with the, we touched upon this earlier, the alignment thing. I've seen this I've often a patient has come to clinic with a letter from a practitioner on a high street with a picture. It's a common thing you see, a picture of an x-ray of someone's spine, which is a normal x-ray with lines drawn showing the contour of the spine, and next to it, a picture of their spine showing the contour of their spine, and then been fed this belief that that's why they have pain. And they're undergoing realignment techniques, adjustments, whatever, manipulations to try and realign it. And obviously they're failing, and that's why they keep going back. But I'm not just critical of various practitioners. This is actually seen in surgery as well. I've seen there's a condition called flat back syndrome, which is a bit of a controversial one. You often see patients in pain. They lose that natural curvature of the spine, as you see on that diagram behind me, and the back becomes really straight. And often that's actually just a guarding mechanism that patients have adopted rather than the structure of their spine. And I've seen patients undergo surgery to try and create a curvature using metalwork, and they failed. And that's something we really need to move away from, this business about the alignment. It has relevance when we have a spondylolisthesis that's unstable, when not so much the alignment, but the one bone's actually moved forward over the other, and you can see on x-rays it's moving. Or if nerves are under pressure. So in scoliosis, sometimes a nerve might be trapped on one side where it's leaving the spine, and there is pain clinically caused by that nerve that you're picking up as a clinician and examining the patient. But that's few and far in between. So that's what we've got, this business about alignment, I think, or trying to realign somebody either with surgery or adjustment. I think we need to move away from that.
Yeah, I totally agree. We actually find in the practice that those are some of the most difficult beliefs to overcome. Because for the average person, quite rightly, you look at two pictures, one looks like a perfect spine in inverted commas, and then theirs has got a curve that isn't on that perfect picture. And it makes sense in their mind, like, oh, why is mine not like that? That must be the problem. And to try and persuade people that, no, actually, your spine is just a variant of normal, and that's probably not what's causing your pain. It can sometimes be a difficult thing to persuade people of.
That's right. Completely agree.
I really appreciate your approach there, and I think it's really helpful for people to hear it from a surgeon that, actually these things are not necessarily the things that are causing your symptoms there. So if you could change just one thing about how back pain is maybe perceived by the general public, what would that one thing be?
In general, the majority of it is not pathological. Again, it's not a disease. Your spine, you haven't ruined your spine. It's not a disease. provided we've excluded any pathological cause, the pain also doesn't necessarily correlate with any harm you might be doing during an activity. So the key thing is to just keep moving, try and move through it. And that's my core belief. My strap line is keeping people moving. I think that's really important.
Yeah, I agree. I think that's such a nice strap line to have.
Yeah.
So I know both yourself and me, Anthony, have got YouTube channels, and we share information online and try and help people with back pain. Obviously, we're not alone. There's a lot of people online who are sharing either sort of evidence-based approaches or so-called quick fixes to help people with back pain. I often say it's still a bit of a wild west out there for people trying to get good information to help them with their health. Do you have any tips for people, kind of how to like filter out the bad from the good when they're looking at online information?
It's a really tricky one. I don't like I don't like criticizing people. I think when we over medicalize a condition, it's a problem. So devices is a key one. People trying to sell various things that you lie on to realign your spine. We often see these short videos of a disc ballooning out of a model and things like that, and then a piece of kit that you can lie on to straighten your spine, or people offering cracking techniques and things like that. The devices I'm very weary of. There's a huge industry now on ergonomic chairs, standing desks and all that sort of stuff. They have a role, the standing desks, in moving from standing to sitting. But these are the things you've got to try and filter through, to try and demedicalize it a little bit.
Yeah, I think that's a really important message. I'm going to ask you a question now that I've always wanted to ask a spinal surgeon. And that question is, what do you do personally to ensure that your spine is healthy?
It goes back to earlier. All the evidence suggests maintaining good general health, rather than very focused spine health, has a long-term better effect. So I enjoy exercise. I use a gym. I actually do boxing, which is contrary to what a lot of neurosurgeons advise you to do. And I eat healthy. I enjoy looking after my health in general. And you can see I'm sat in this chair. It's not an ergonomic chair. I'm slouching through this whole interview. So I look at my general health when I'm not sat at my desk.
I think that's really important. And boxing, what a great form of exercise, just if nothing else, just to burn the calories, but keeps you agile, keeps you moving.
Right.
And as long as you're not taking too many blows to the head, then it's probably okay.
Because it combines the strength training, which we need as we age, because we know muscular bulk declines and muscular strength is one of, a correlate of longevity, but it also has good cardiovascular effects, which are also good measures of longevity.
Yeah.
Correlates.
Totally agree.
Yeah.
So I often think about this next question for myself, as if I'd never done physio school and become a physio, what would I be doing instead? I still don't really have a good answer from my point of view, but I'd love to throw that question to you. If you had never got into spinal surgery and you weren't a doctor or a surgeon, what do you think you would be doing instead of this?
I think definitely something health related. If not longevity, there's a lot of longevity medicine now that's kind of blown up. Andrew Huberman, Peter Attia, who I love. I love listening to their podcasts. Maybe as a non-doctor, I'd probably do something related to fitness. Just something related to fitness. I think helping people keep fit.
It's been amazing how much the longevity thing has blown up in the last few years, and you've got these these great guys online, like you say, Huberman, Peter Attia. The information they provide for free is fantastic. And then you've got these like extreme cases like Brian Johnson, who are doing self-experimentation, and it's absolutely. It ranges from like super sensible to almost quite crazy.
Extreme.
But it shows how popular as a topic longevity is becoming. I agree. I think that would be a really, really interesting field to get into if you weren't doing what you were doing now.
Yeah.
As we bring this part of our interview to a close, Anthony, if you could just give one piece of advice to someone who's suffering with back pain at the moment, maybe they're scared, they haven't seen a doctor yet, they've had this back pain for a few months, it doesn't seem to be getting better, if anything, it's getting worse. They don't really know where to start. What should they do first? What should they avoid? What piece of advice would you give that person?
Well, firstly, look out for the red flag sign. Provided you don't have pain, numbness, or weakness in any of your limbs, the likelihood, the big advice I want to tell people, the likelihood is it's nothing serious, despite the level of pain you're in, and there is light of the tunnel. There is a way out of it. If it's gone on for some time, being assessed is helpful. That doesn't have to be by a surgeon. It could be by a good physiotherapist, such as yourself will. Having a good assessment and that reassurance that there isn't anything pathological going on, so a good clinical assessment is really important. Once we've excluded that anything serious is going on, trying to get you moving again, back into your normal lifestyle is really important, trying to get you moving again.
Yeah, I love it. That's such a great piece of advice to finish on. And, movement is key. And as we see in the practice so many times, just many back problems can be solved from doing the right kind of movement and keeping going. So, no, I really appreciate you coming on today, Anthony. I think you're absolutely fantastic.
Pleasure.
Your approach is pragmatic, it's sensible, it's modern, it's up to date, it's evidence-based. So really appreciate what you're doing. And obviously at the Spine MDT sounds like a fantastic place for people to get care.
And I just want to say, Will, I really like the work you're doing. I think it's I think in a lot of medical specialties, we kind of focus in onto diseases or conditions rather than age demographics. And I think what you're doing is really amazing work.
Thank you. I really appreciate that. And we're actually going to continue this interview on the Lifelong Mobility platform. You can find details of that below this video. But before we sign off on YouTube, Anthony, just tell people a little bit about where they can hear more from you and get in contact with you if they have a problem they want to get help for.
Well, thanks. Well, I suppose the best place is either my website, which is spinemdt.com, or my YouTube channel. There's a video out every week. The tag is at spinemdt.
I definitely recommend the YouTube channel. Everyone go check it out. Subscribe to Anthony's channel. And thank you so much for coming on. I really look forward to speaking to you again soon.
Absolute pleasure. Thank you.